Welcome to the National Professional Development Seminar. This is our fourth installment of them, and they've been really great. So I hope that you all get involved tonight, ask some great questions, and really get the information that you need. We've got an excellent group of surgeons tonight to talk about both urology and transplant. Before we get to that, though, I do want to put a plug in for the Committee on Medical Student Education program at the American College of Surgeons Clinical Congress. While that happened in October, it is still available online. You can go online and register and see the whole thing, and there's lots of great information out there for medical students. I'm Jake Quick, University of Missouri. I'm actually a trauma surgeon. I wanted to be a transplant surgeon, but I wasn't smart enough. So we're going to learn a lot tonight. We're going to start with the urologist. So if you all want to go ahead and come online here so everybody can see you. And I'll let them introduce themselves. We'll start with Dr. Cross.
Hi, thanks, Dr. Quick. I'm Brian Cross. I'm an associate professor of urology and urologic oncology at the University of Oklahoma in Oklahoma City. I'm originally from the East Coast. I did my medical school at St. Louis University in St. Louis. I did my 5-year urology residency at Emory University in Atlanta and my 2-year urologic oncology fellowship at the University of Pittsburgh. And I've been in Oklahoma now for 6.5, going on 7 years, be 7 years next summer. And so I'm excited to be here, and thanks very much for the invitation.
Dr. Rahman?
Hi, good evening. My name is Jay Rahman. I'm a professor of urology at Penn State Health in Hershey, Pennsylvania. I did my medical school at Cornell University Medical College in New York, as well as my residency at New York Hospital Cornell. I did a fellowship in minimally invasive surgery at Southwestern Medical Center in Dallas. And Hershey's actually been my first one and only job. I started here as an assistant professor about 14 years ago, and now I'm the department chair of urology.
All right. Finally, Dr. Santiago Lastra.
Thank you so much for this invitation. My name is Jair Santiago Lastra. I am a urologist specializing in pelvic medicine and reconstructive surgery at UC San Diego Health. I went to medical school at the University of Puerto Rico, where I'm from. I did my residency training in the Harvard program in urology at Massachusetts General Hospital, and then did my fellowship in pelvic medicine and reconstructive surgery at the University of Michigan. I've been in practice for 4 years at UC San Diego.
All right, great. Well, let's get started with a question. How does one become a urologist?
I can take that.
Take that.
Yeah, I can take that one. Thanks, Dr. Quick. So urology is a surgical subspecialty that you match directly into out of medical school. So most urology residencies are 5 years, just like general surgery residencies. There are some in the country that are kind of holdover 6-year programs that they incorporate a year of research, but many of those are transitioning to 5 years. But urology is a surgical subspecialty, very much like ENT or orthopedics, that you match directly into out of medical school. Most urology residency programs will incorporate some amount of general surgery. That has changed a little bit over the last few years, in that urology interns used to be under the general surgery department as interns, and so they would do basically a full year of general surgery. At Emory, I did 18 months. And that is changing a little bit now that the urology interns are under the urology department, and that gives the urology department some control over the rotations that they do. And I think that most urology programs are backing off a little bit on the amount of general surgery that the interns do. I think maybe the other panelists can speak to their institutions. I know at OU that we do 6 months of general surgery and 6 months of urology. But then the urology program in total is 5 years. And then as the other panelists have said, there are fellowship opportunities after residency if you so choose, but many don't. And they go directly into practice, either in private practice or as general urologists in the academic setting.
Is that similar for you there in Penn State, Dr. Rahman?
It is. I think what Brian really highlighted is an evolution in urology to sort of a more integrated, inclusive residency, where most of us, for example, when we went through training initially did 1 or 2 years of general surgery. And now in these integrated programs, I think the ACGME requires 3 to 6 months of general surgery, and I think it varies from program to program. And I think as Brian highlighted, some of the elements that, for example, at Penn State, where we try to have our interns are domains that are related to urology, perhaps. So, for example, transplant surgery is a logical one that's related. Maybe colorectal surgery, because we do a lot of bowel work for some of the urinary diversion. So we certainly try to highlight the areas of general surgery that sort of juxtapose with our practices.
I would echo what my two colleagues have said. What I will say that I've seen that I think is really positive about that preliminary year prior to beginning the categorical years in urology is that in addition to 6 months of general surgery, which is what we'll have our interns do, they'll also get some elective time in which we have them spend some time, for example, with interventional radiology, because a lot of our endoscopic techniques are very much shared with that specialty, and we like for them to become really experts at the imaging modalities that we utilize for a lot of the procedures that we do. And then another thing that I think is really important for the medical students to know is that urology is an early match specialty. We participate in the early match process. Additionally, urology is a specialty that has several subspecialties within it. So even though it already seems like a subspecialty, it really is a field where there is a lot of breadth. There's oncology, stones, pediatric urology, infertility, male sexual health, female pelvic medicine and reconstruction, and then urogenital reconstruction, and even a little bit of trauma. So when you embark on that career in urology, there's still a whole breadth of things. And then we are also a surgical specialty that integrates a lot of medicine. We are very familiar with nutritional management, for example, in patients who have stone disease. And a lot of the treatments that we offer, for example, for erectile dysfunction, require us to know also about comorbidities like cardiovascular disease, hypertension, et cetera. So it is a huge breadth of expertise that comes with our specialty.
Yeah, and just to expound on that point that Yahir brought up, I think it's very important for the medical students to understand about the early match. Our match is in January, whereas the regular match is in March. So that sets the timeline back a little bit for medical students if they are interested in urology. And urology is one of those fields that very few people know about when they go to medical school. I mean, very few people go to medical school thinking they're going to be a urologist unless, their parents are a urologist or they know somebody. I certainly didn't know much about urology at all and just kind of stumbled into it, so to speak. So if you feel like you're interested in urology, it's something that is, it is important to get some early exposure to, go to the clinics and even go to the operating rooms to sort of get a feel of what it's really about, because the away rotations are important. It's a little bit different now with the pandemic, but hopefully once this is, in the next few years, the medical students will be able to do the away rotations again. And then the application timeline is set up a little bit in the fall. So that's something important to know.
Anybody else want to add to that, or?
No, I think here hit a really important point, which is really that there is a real spread of domains within urology. And I think it's really funny to think about a subspecialty having subspecialties within it. But the great thing about it is you can choose, as the three of us have, to focus in a particular domain if you so chose, oncology, for example, female pelvic medicine, reconstruction. The reality is the vast majority of urologists practice the entire spread of the disease. I mean, most urologists, to be honest, are not in academic medical centers. They're practicing in the community and they see the full spectrum, maybe stone disease for one patient, the next patient may have cancer, the next one may have benign prostatic diseases. And I think that's what really is so great about the specialty. I love to say that it never gets mundane because you always might see something different, whether that's within your area of expertise or even crossing domains within the field of urology.
I raised my hand because I wanted to make just a couple more points. One was, as somebody who thought that she was going to be an orthopedic surgeon and who really late in the game became exposed to urology really by accident, and I actually tried to switch out of the rotation. There is hope if you decide late in the game that you want to be a urologist. It makes it a lot easier to have early exposure, and that's why we love hosting these webinars to make sure that you all have the information that you need to know that urology is such a dynamic and rewarding specialty. And then the other part that I think is really important for applicants to know is that there is a huge need for more urologists. There's actually a huge need for urologists in certain parts of the country that are very underserved with urologic care. So it is also a well-compensated specialty where it is possible to have a good work-life balance and where you can be assured that you will be able to get a job once you finish your residency.
I think you here hit a great point there, which is from a job when obviously as a medical student, when you finish medical school, you really want to know that you'll have a job and you'll have some job security. And I have to say that, for those of you that do any economics, if you look at supply and demand curves, the supply and demand curves for urology very much work in the favor of graduates. I mean, it's an aging population, baby boomers. And the urology RRC has largely really restricted the number of graduates coming out of programs. And so to her point, there are excellent job opportunities. And that's a really nice thing. I feel like you go through all of medical school and you want to be coveted at some point. And it's nice when you're finished with your training to have a specialty that covets your needs and allows you, I think, to pick to some degree within reason where you might want to practice and what your specialty might want to be within the domain of urology.
Well, you guys have all touched on it a little bit, but do you want to talk about how you came about to go into urology? What was it that drew you to it initially?
So when I was a medical student in St. Louis, I wanted more, I guess you could say, exposure to the surgical subspecialty. So I went to our medical student coordinator and I said, I just want to. It was the summer between my first and second year, and I said, I just want to hook up with a surgeon and shadow him over the summer because I had some time. And he said, well, how about a urologist? And I said, well, I knew so little about it. I didn't even really know it was a surgical subspecialty. And so I said, okay. And so I got involved with the residents in St. Louis, and they took me around and they got me involved in the operating room. And I think that, that was really my very first positive clinical experience. And I think that goes a long way in deciding what you're going to do. If that was orthopedics or ENT or general surgery or transplant or whatever it might be, it might be, in a different situation now, but it was urology for me. And I never really sort of looked back from there. And so I liked the people. The more I looked into it, I liked the field. I liked the variety, like Dr. Rahman has brought up. And so that really got me interested, and I never changed from that.
Yeah, I thought I wanted to be a cardiac surgeon when I went to medical school, and very similar to what Brian said. I during my first going to second year of medical school, I just happened to be scrubbing into a case, and it was a kidney cancer with a cable thrombus. I didn't even know urologists did that, frankly. And the chair of urology at Cornell was Darricott Vaughn, who's just he was one of the real gentlemen in the field. And he's doing this complex operation. He's asking me where I grew up and what I did for fun. And it really, as with almost anything, right, your lens of how you look at things is often colored by the interactions you have with people. And I found him and then his colleagues to just be really nice surgeons, nice people. And we all want to work hard, and surgeons really, you love to operate. But it was just a really nice group of people to come in contact with and interact with. And then I would be honest and say, look, many of us, you talk a lot about work-life balance, and I do think it's a specialty that really does give you work-life balance. I mean, many of us, and I happen to live in a more rural area, so I live 6 minutes from where I work, and so I can put a long day in, still make it home for dinner, make it to my kids' soccer practice, and in reality, there are some emergencies, but there are not many, and many of them, from a work-life balance perspective, can really be arranged around your schedule. So I think that's another big factor, which nobody wants to talk about, especially early on as a medical student, but at the back end of it, it sure does matter.
I have to 100% agree. I mean, I think when I begrudgingly did my urology rotation, what really attracted me to the specialty, first of all, were the personalities. I still remember Dr. Carrion, who was a general urologist at the hospital where I was sent to rotate on my community rotation, which was in urologic surgery. And he would play, grand opera when he was doing an artificial erection on a patient who was getting a repair for Peyronie's disease. And it was just so dramatic and flashy and fun. And the patients in his clinic were all so happy there were patients that he knew for a long time, patients that he had just operated on and would probably not have to follow up with him any further, but patients that really improved from their surgeries and were so appreciative. And then the other thing that I loved was that you could tell he had an excellent bedside manner when talking to patients about things that are so devastatingly embarrassing or intimate to them. And he was able to, have them get their guard down and make them feel comfortable, all the while being such an excellent technological surgeon. And then one day would do, cases where he's inserting a prosthetic, and then another day would do this gigantic open case where he would remove someone's bladder who had cancer, remove their prostate, and then create a new bladder made out of bowel with a catheterizable channel. And so to me, that was just so amazing that a specialty could offer all of that. And I was pretty much hooked then. And I think when I look at my colleagues that I work with on a daily basis, they're all people that I want to be friends with. They're people who really love what they do. They're really, they're intense. They take their job really seriously, but it's urology. So we have to have a bit of a sense of humor because what we're dealing with sometimes warrants that so that people feel comfortable.
Is it true that urologists have the best jokes?
Yes. Yeah, it has to be. Yeah.
I think they do. The urologists here are some of my best friends. So when you're thinking about going into urology, what makes you a really strong candidate?
It's a great question, and I'll tell you, it's one of the things that I think is evolving, to be honest. So I think we all see this with the medical students increasingly, as we know that step one, for example, is no longer a numerical score. It's going towards a pass-fail grade. So step two is still there. A lot of medical schools have transitioned towards non-graded systems. So I think some of the historical conventional objective metrics, what's your step one score, what's your step two score, how'd you do in your clinical rotations, sometimes it's harder to tease out now. I do think that one of the elements that really sort of distinguishes is if you're able to somehow connect with a mentor to do some research. And that's hard. And Brian mentioned it's an early match. And so the timeline is accelerated. But I do feel that when you have a lot more of these characteristics whereby you don't have real objective data on, for example, performance in different realms, being able to do some amount of research sort of shows your interest. It shows perhaps your ability to complete a project. And it's something that perhaps distinguishes you from some other candidates.
For those of you that are a bit more non-traditional or perceive yourselves to be atypical applicants, just know, I was an atypical applicant. I had zero research in urology. And when I evaluate applicants now in our residency program, and as far as deciding who we're going to invite for an interview, I think that research is definitely important. And I think doing significant research where you took a significant role in the development of the research plan, you did a lot of the work of that research, and we see it go to fruition. So it was presented, it was published. That matters more than whether or not it's a project in urology. I had some projects in HIV, I had projects in orthopedic surgery, but they had been my projects. And then the other thing that I think helped me stand out as an atypical applicant who was coming from the University of Puerto Rico, which historically has been quite challenging for students to gain interviews when coming from the island as opposed to coming from the mainland, it was that I had a lot of community engagement. So when we look at applications, research is important. Urology research does help. But what matters more is the quality of your scholarship when you were in medical school. How did you do on your grades? If they were pass fail, what do your letters say about you? Do you know your mentors? Can they vouch for you being an excellent applicant? Are you engaged as a physician in your community? Do you work in the service of others? Does your research show a scholarly mind? And those types of attributes are what sets people apart. Whether or not that takes place in urology, we understand if you were exposed to urology late. Does it help to be exposed early? Absolutely. If you're exposed late, if you're an excellent applicant, I think you still have a great shot.
Dr. Cross, you mentioned earlier about away rotations being fairly important. When do you think you should get those scheduled? Where should you go? What kind of places should you look at?
Yeah, so good question. So I'll go sort of pre-pandemic, and then I'll talk about how the pandemic affected that and sort of hopefully where we're going after the pandemic is quote unquote over. But so before the pandemic, most medical students chose to do 2 away rotations. They would do their home rotation probably in July of their 4th year, which is usually a month. It's like an acting internship or what we call sub-I. And then they would do 2 away rotations at places that they're interested in matching, because that's basically, I think that if you look at where people match, it's many times either their home program where they know them or where they rotated. And it's basically, they got to know them for a month. And so that's where I matched. I rotated at Emory and I matched there. So I think that most students elected to do 2, and they would do basically their home rotation in July and away in August and an away in September. And by that time, that's about the time that the applications are due. And many times some of the interviews will start in the middle part of October or late part of October. So that's sort of the timeline. Last year, they were not able to do any, the students weren't able to do any away rotations. This year, they were able to do 1. Potentially, if again, when the pandemic, potentially slows down, they'll be able to get back to doing 2. It's changed a little bit from when I was going through it, in that when I was going through away rotations, I just emailed the coordinator and said, hey, I want to come in, August. And they said, okay, we'll show up on this day and, you can be here for 4 weeks. It's a little bit different now in that, at least from what I've heard from our students, they have to apply to get away rotations. And even some places are requiring letters of recommendation for an away rotation, which I think is a little bit ridiculous. But so the away rotation timeline is basically starting in the spring. So March or April of the 3rd year, students are trying to arrange away rotations for the summer of their 4th year. And as far as where to go, I think most people try to target where they might want to match for residency, whether that's where they're from or, a geographic region that they want to be in, or places that they know people. I think that that's where most people, because again, those are going to be your places that that know you the best and probably are going to be the best chance places for the students to match?
I'll just sort of, build off of that. I think, why do you do an away rotation? And I think the one message is you don't do it to go get a fancy letter. You do it because this is a place where you think you could potentially end up. And I think it's important to rely on your faculty mentors, because the questions I ask my students, for example, are, do you envision yourself in a big city or a smaller, more rural area? Are you a big program, which is, maybe 4 or 5 urology residents a year, or do you like smaller programs? That's maybe 2 urology residents a year. Do you want to be in a single system where everyone's at one campus, or do you want to be in a system that has a VA or a county hospital? And I think based upon those answers, I try to direct them as to, hey, I think this fits what you're looking for. You should maybe do an AI or sub-I here and here. And I think the goal is ultimately for the candidate to get the best sense of a program, not just go somewhere to get the best, the highest ranking person's there letter or sort of the bling factor from a fancy letter from somebody.
Yeah, I 100% agree that the away rotation goes both ways. I mean, it's a time for the program to evaluate the applicant, but it's also a time for the applicant to evaluate the program, because I mean, as you know, I mean the half-day interview, it's very hard to get a sense of sort of the quote unquote culture of the place. I mean, certainly now that it's virtual, many of all our interviews now are virtual, but even in person. So that month being at an away rotation I think is very important for the student to know, see how the residents interact with one another, see how they interact with the attendings, get a feel of the place, and because it's going to be somewhere they're going to spend 5 years. And it's, if it's not a place they're going to fit in, or it's not a place they're going to be comfortable, that's something that they should figure out as a medical student rather than as an intern.
Again, agree. A few points that I wanted to make with respect to urology, rotations, letters. Urology is a small field. So, we're a small community, and in the academic programs, we tend to know most people, or at least one person in the program amongst programs. And so the letters are important because you're like, oh, this is my friend over at Penn State. I've read his letters. I can tell he knows this applicant. He's really behind this applicant, and we place a lot of value in the impression that your mentors will have of you and what they say about you in those letters. So those letters go a long way. And then with regards to the away rotations, it really is an opportunity for you to allow people to get to know you and to see about fit. Again, because urology is small, even the largest urology departments will be way smaller than an OBGYN or a general surgery department. So personality and fit and fitting in during that time is really important because it's a smaller family. Again, the personalities are going to be really accepting for the most part, but when you do those away rotations, you want to get a feel for that too, and wonder whether you can be happy there and fit in that surgical family for those 5 years.
Well, we've got a few minutes left here. One of the questions from the chat was, tell us about your typical day as a urologist. Dr. Santiago Lastra, you gave a pretty good answer there. Did you want to elaborate on that?
Yeah, I think one important thing, I'm in academics, so in addition to like what my typical job is clinically, a lot of the times I will have a meeting with the residents, like a resident lecture on Wednesday. So I lecture the residents about different topics. We round together if we have a postoperative patient. Usually I only have like one admission in the week because my subspecialty tends to be heavily on the outpatient side. But some of my colleagues who do oncology interact more with the residents on the inpatient side as well. And then additionally, sometimes I'll wake up very early to review a manuscript, to edit a project, to submit a grant. So my academic pursuits also play into my day. Just like Dr. Rahman was mentioning, my day starts at around 6:30 when I arrive to the hospital, and I'm usually home by 6 o'clock. And the pandemic has really alleviated some of the later meetings. And typically those are on Zoom, and you can see my kid bouncing around in the background. So I'm home for dinner, thankfully.
We've got 1 minute. You guys have anything to add to that?
No. I mean, I think she hit all the high points. I think that as far as what the typical day or week looks like, I would think that it's important for the students to know that I would guess that at least in academics and probably in private practice too, that the urologist is going to spend 2, maybe 3 days a week in the operating room. Not going to be in the operating room 5 days a week, like potentially some surgical subspecialists are. And that's one of the things that many people like about urology, that there's this good mix of clinic and OR. I would imagine, I mean, for me at an academic place, just like Yahir said, I mean, I'm in the operating room 2 days a week and clinic 2 days a week and have an admin day. And I would say that that's probably how it is for most people. Dr. Rahman maybe can speak to sort of what it is at the chair level. But I think that's pretty common. A couple days a week in the OR, a couple days a week in clinic, and some administrative time.